Hi everyone, this is Neil Wright, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who has attended previously with a keratosis obturans in this ear. And I'm just having a look when they last attended. It was October 2024, so about 8 months ago. And this procedure was performed on the 9th of June. So I did recommend that they attend every 9 or so months because the previous occasion they attended was extremely difficult. And I initially saw the patient in 2021, and I think on that occasion it took me the best part of an hour. On that specific visit, the patient was several years prior to getting their keratosis obturans removed. It was the first time I saw them in 2021. So with this patient, because of how on previous visits how difficult it was to remove their keratosis obturans, I recommended that they use sodium bicarbonate earwax drops for just a couple of days, 2 or 3 days prior to attending, because it really just helps to soften the skin. Otherwise, it's extremely dry and hard, and it still was once I removed this more lateral layer. But by attending more frequently, we're trying to extract all this epidermal skin before it forms into an epidermal plug and then enlarges and widens against the ear canal. And keratosis obturans, if anyone has it, the hallmark symptom is otalgia, so ear pain. So we want to make sure we see the patient on a regular enough basis, preventing it to getting to the state it was when I saw them a few years back and last year. So I've removed the occluding dead skin, so the drops worked really well with that. And you can see the eardrum in the distance. It's very opaque, and they've just got some wax, dead skin here at the roof of the ear canal. So I've removed that occluding softish, wettish wax skin in the center of the ear canal. But now we're left with the task of peeling away all this dead skin, not only from the ear canal, but also off the eardrum. So if you take a mental image of what this patient's ear canal looks like right now, you can see it looks really dry, wrinkly, hasn't got a good complexion, and this skin is extremely thick. And I'm just trying to peel it away from the posterior canal wall first. And I'm just trying to, as I'm peeling, I'm bringing the suction tip back into the middle and going back. When you've got very thick skin like this, it's almost got elastic memory. It wants to rebound back on the canal wall, and you'll see that on quite a few occasions during the course of the procedure. But so far the skin is peeling towards the eardrum, which is good. More at the top back portion of the ear canal, so we call that the posterior superior quadrant of the ear canal. I think I'm just going to go back in a moment, just get this bit of, it looks like more wax and dead skin, if truth be told, at the top of the ear canal. I was going to get that away. They have got quite a narrow entrance of the ear canal, which can make it a bit difficult to gain access, but more so to manipulate the instrument. So with the suction, when you've got really thick skin like this that wants to rebound back into its original position, you want to really use the suction tip or the forceps to peel it completely away. And because you've got a narrow space in there, there's only so much you can maneuver your instrument. So there's a bit of skin here that's partly off the canal wall, so I've got something to grab onto, but it's just flapping with the suction this at the moment. So I'm going to find another reader. I'm going to go to the bottom, and I'm going to probably come back upon myself near the entrance and start peeling here. And what I was finding, eventually the skin actually did peel off the canal wall quite well, but it's attached to the eardrum. That was the most difficult part. And although it peeled off the canal wall pretty well, every time I came out of the ear, it just bounced back. So it has got that kind of springy elastic memory. So you can see it's peeling quite nicely. We're going forwards. And the underlying skin, it looks nice and healthy. So that's the outer layer of the epidermis skin, stratum corneum we call it. And all this skin that I'm removing was once upon a time that more fleshy pinky skin that's lining the ear canal, but this skin has since desquamated, so shed, but it hasn't shed in a normal manner. Typically this skin that you're seeing that I'm peeling away, as the skin dies and sheds, it migrates sideways towards the entrance, and once it reaches the outer third of the ear canal, the sheet of dead skin is basically interlocking individual skin cells, corneocytes, and they're bonded together almost like armor, so like a chain, body armor. But as you reach the outer third, the individual skin flakes detach from one another and they flake away. But with Keratosis obturans, two things typically happen. The skin doesn't migrate laterally, it doesn't migrate from the deepest part of the ear canal to the entrance. Quite often it tends to migrate inwards into the middle of the ear canal. And also, with Keratosis obturans, what's quite a common feature is that those individual corneocytes, those skin cells that form the outer layer of skin, they fail to disconnect from one another, so they remain attached. So you get long sheets of skin, almost like an onion. You almost typically get layers. Now, you won't see those kind of layers in a typical Keratosis obturans in this procedure because we've got this patient back on a regular basis before it gets that bad. And we call that a lamellar structure. So I've just put some drops just to get underneath this skin. And this is really going to help lift it up. What's also difficult, because the skin does bounce back, it's then difficult to use forceps because you want some of the skin to remain in the middle of the ear canal so you can grab onto it without the jaws of the forceps coming in close proximity to the canal wall, because we are working on the bony part of the ear. And I'm speaking from experience because I have had trauma to my ear before on the bony part, so I know how painful it is. So you can see that skin from the back part of the ear canals, it's completely elevated off the ear canal wall, and it's stuck to the eardrum. And so ideally I want to wriggle this left to right, but there's not much space left to right because of the narrowness of the ear canal. And I'm trying to come away with this, but I can feel there's something not allowing me to pull this completely away. And you'll see it in a moment. There's some granulation tissue at the base of this skin. So to the left, you're beginning to see the eardrum. So I'm trying to peel left to right and outwards at the same time. So we are revealing some of the eardrum there. But as you can see, I've come out the ear, the skin's just gone back. It's as I said, got this kind of elastic memory. It's gone back to the original position, so I'm going to have to try to work it again. And we're going to use some forceps in a minute because I think when I go back in, the skin is in a position where I can grab onto it. But if truth be told, the forceps wasn't really that beneficial, although it did help me peel some of it from the front part of the ear canal. I know sometimes you read the comments, why don't you use the forceps? Well, we do, but when they're effective, and this is a classic example, it's not always effective as one may imagine it would be. With the forceps, they've got these little micro serrated jaws, and when you grasp or clasp onto soft tissue like dead skin, it can cut it away. As you can see, now that some of the skin is not bouncing back, I'm trying to get the jaw underneath it, and I have. And the secret here is also not to close the jaws too tight, because you will cut through. So you're just trying to get that fine balance, but you can see it's just cut through that. So then I'm going to go back to suction. I do use forceps again a bit later on the front part of the ear canal. I'm just trying to peel it down from the top and from the right hand side of the ear. It is like stripping wallpaper off your wall, but obviously the difference here is the wall is the patient's ear canal, so we don't want to cause them any discomfort or trauma. And this patient was fine completely throughout. I mean, they're used to the procedure now, so we've seen them several times, and although it's 18 minutes long, previously it's been up to an hour, so they're very accustomed to remaining still and having this removed. You can see it is peeling away. It's come off on the floor of the ear canal completely, and it's just the right hand side of the ear now. I'm using this tugging motion, so it's nice and gentle. It may look quite aggressive in the ear, but you're just kind of rotating in circles, going forwards and backwards in circles. I did ask the patient if they were okay, and they said they couldn't feel a thing, which is really good to hear. As you can see, it's coming away from the top. I'm trying to peel it right to left. And you're going to see some granulation tissue at the floor of this skin in a moment. And they have got some irregular contours of the ear canal, for example, bottom right. There's no ulceration there. And that's where that granulation tissue was. You can see that on the floor. It's at 3 o'clock on the screen. You can see there's a bit of an indentation in the bone. So there's some bony remodeling occurring there. So with keratosis obturans, the ear canal can widen, not only through the sheer pressure of the epidermal plug compressing against the ear canal, but it can activate osteoclasts, which are specialized bone cells that live on the surface of the bone. And that's secondary to the periosteum. So periosteum is a thin membrane, if you like, that sits on the bone, and it nourishes the bone, provides it with all the oxygen, blood, energy basically to sustain life. And when you've got a keratosis obturans plug up against the canal wall, it aggravates the periosteum, which then sets off the osteoclasts. And what the osteoclasts do, they break down bone into its core minerals and tissues, and it redistributes those broken down minerals and tissues into the bloodstreams, where elsewhere in the body new bone can be formed. And that's the formation of new bone is undertaken by other specialist bone cells called osteoblasts. So with keratosis obturans, they initiate osteoclasts, and that process of the tissue of the minerals and tissues of the bones being broken down, we call that bony resorption. And the net effect of that is that we have bony remodeling. And with keratosis obturans, it's normally global. It's not at a specific point in the ear canal, so it's not localized. It's more the circumference. There can be variations. Now, I think I put this patient down as a grade 1, grade 2 keratosis obturans when they last came. Once you've developed this bony remodeling in the ear canal, I think it's a question that someone else asked in the past. It's a good question. Is it possible that new bone can be formed in the widened part of the ear canal? And unfortunately not with keratosis obturans. Once the bone has been remodeled, it is a permanent fixture. Sometimes after performing a procedure on a keratosis obturans, because especially at a grade 2 or 3, the portion of the ear canal in front of the plug, the epidermal plugs, is typically the cartilage region, probably some of the bony region as well, but not deep in the ear. You get inflammation there, and so therefore you get some swelling. So it gives you the pseudo appearance of the canal wall where the plug is to be wider than it actually is, because the section of the ear canal in front of it is narrowed because it's swollen. So it gives you that pseudo appearance. So you're going to be sometimes just be wary of that. I've had that in the past where I thought, oh wow, this is really, really widened, so I'll probably categorise it as a grade 3, but when the patients come back on a subsequent visit, it's not as wide as I initially believed it to be, and that's because the swelling in front of it's gone, so the ear canal has a more symmetrical diameter and width throughout. And there you go, it's peeling away. There's no really quick, easy way of doing this. You're just going to be patient. You're going to tug away. One of the things that you may not be able to see, and you may be, is how much actually force I'm applying. And it's the bottom right. That's where I can feel that it's stuck on the bottom part of the ear canal. And all this skin to the left, it may look like it's still attached to the ear canal wall, but it's not. We peel that right at the beginning of the procedure, actually, but it's just flat back, as I mentioned. So that will come away easily because it is actually detached. It's the bottom right, you can see there. Now I'm getting some traction. And I think it comes away, and it came out in one long cast of the ear. I just didn't have time to take a photo, unfortunately. So that's the ear canal. It's got a fresh layer of epidermis skin that's visible, so you can see the difference. And the eardrum, now they have got quite opaque eardrum anyway, but it looks a lot healthier than it did before when you had that thick blanket of skin. I'm just mopping up near the entrance. There's just some sticky wax, dead skin. It's just in here, just before the second bend on the right. So the midsection is a bit of a widening, so I would go with more of a grade 1 on keratosis obturans. So grade 1 is when you've got minimal widening. Sometimes it's not always visible. Grade 2 is when it's moderate widening. Grade 3 is when you have granulation tissue. And grade 4 when it's really, really severe and it's invaded the mastoid region at the back of the ear. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon.